We welcome Professor Kim.
Thank you for kind introduction. I'm very glad to be here and honored to present my subject in this great meeting. And also I'd like to thank Dr. Chan, the chairman of president of Hong Kong Urology Association, and also thank Fering for inviting me this great meeting. I'd like to present the efficacy and safety of Degarelix, a new treatment for hormone-dependent prostate cancer patient. Also, I will introduce my hospital briefly. My hospital is the Asan Medical Center, located in the east of Seoul. And just the southern part of Han River. We have 3 hospital buildings, which is 2,750 beds, the biggest hospital in Korea, and we are referral center for serious disease. We are very famous for organ transplantation, like a liver or pancreas and heart. Also, we have many reports like NEGM with heart disease. Also, we are famous cancer, also famous of prostate cancer. And this 2 buildings is Asan Institute for Life Science for the research. Actually, I'm in charge in this building. And we also have a guest house for the Korean or foreign doctors. If you have any chance, please visit our hospital. Our hospital also designated research-driven hospital by government in this year, and also designated Global Center of Excellence in Clinical Research, clinical trials. My presentation is composed of introduction and the C21 study, which is non-Asian study, and CS42, which is Korean study. And lastly, I'd like to comment new data for Degarelix from 6 randomized trials. As you know, the LHRH agonist stimulate the anterior pituitary gland initially and downregulate the pituitary gland hormone secretion. So there is a surge of FSH, LH, and testosterone, and there is a microsurge on repeat injection, and the FSH suppression is not maintained a long time. In contrast, Degarelix shows rapid suppression of FSH, LH, and testosterone, and there's no microsurgery, and FSH, LH, testosterone suppression is maintained a long time. So GnRH agonist has some initial flare-up about after 2 days. So Degarelix is a synthetic peptide modeled on body's own GnRH. It's a 3rd generation GnRH antagonist, and composed of 7 synthetic amino acids. CS21 is a multi-center randomized trial comparing efficacy and safety of Degarelix with leuprolide in patients with prostate cancer requiring ADT. It's a non-Asian study. The patient randomized into 3 randomized arms. The first and second is Degarelix arm. In first arm, the patient received 240 milligram Degarelix as initial dose, followed by 180 milligram of Degarelix monthly basis for 12 months, and the second arm received 160 milligram of Degarelix, also for 12 months. The third arm patient received leuprolide. Degarelix shows immediate testosterone reduction, so there is no risk of clinical flare. 96% of Degarelix patients have already achieved the castration level in just 3 days, but leuprolide induces testosterone flare, and that can cause some worsening of a symptom. And the Degarelix maintained the testosterone suppression over 1 year, but after 1 month, leuprolide shows similar effect. Degarelix also reduced PSA faster than leuprolide, so it shows low PSA level at day 14 and 28 than leuprolide. Degarelix has no microsurgery, but leuprolide has still stimulate testosterone level after 9 months. There is a tendency of a longer survival with Degarelix compared to leuprolide, but in this study there is no statistical significance. Also, Degarelix reduced LH level rapidly and sustained the reduction. Also, Degarelix reduced FSH rapidly and maintained the reduction. But the leuprolide, in case of leuprolide, they showed only 50% of reduction of FSH. We don't know about the ejected role of FSH in prostate cancer, but there is some report about the FSH mechanism. When we look at the changes of androgen and gonadotropin, with surgical castration, it decreases serum testosterone, DHT, but increase LH and FSH by feedback mechanism. GnRH agonist, leuprolide, increase all level of hormones initially, but immediately decrease serum testosterone, DHT, and LH, FSH, but after then FSH maybe increase up to minus 50% of initial level. But Degarelix decrease all level of hormone, testosterone, DHT, LH, FSH. They are reduced long time. Radu reported the expression of FSH receptor in tumor blood vessel. This is a prostate cancer tissue. They showed high expression of FSH receptor. And also they observed the FSH receptor in other tumors and tissue, blood vessels. Pancreas and rheumatoid arthritis tissue shows no expression of FSH receptor. And the liver and pancreas cancer shows a low level of FSH receptor. And the lung cancer, stomach cancers, ovarian cancer, and bladder cancer shows intermediate level of FSH receptor. But colon, clear renal cell carcinoma, and breast seminoma, and prostate cancer shows a high level of FSH receptor in tumor vessel. Giringeli reported one case. In this paper, the Degarelix showed a new anti-angiogenic agent for metastatic colon cancer, which is failed after bevacizumab, the anti-angiogenic monoclonal antibody regimen. With degalinrostat, FSH level decreased, and CEA level is maintained, and the tumor was in the stable state for some time. And after the treatment of degalinrostat, they showed decreased blood vessel density on ultrasonography. Alan investigate the mechanism of degalinrostat, FSH mechanism. In this paper, they showed FSH increase VEGF, which is a well-known angiogenic factor. So there may be some role of degalinrostat in this mechanism. If some tumor shows have this mechanism, I think that there may be role of degalinrostat in that tumor. But we need more study and research. As a conclusion of a CS21 study, 96 patients of degalinrostat reached castration in 3 days, and there is no testosterone microsurgery, and the degalinrostat showed immediate and sustained suppression from the start, and there's no need for flare protection. The incidence of adverse event were similar between degalinrostat and leuprolide, like hot flush and weight increase. Degalinrostat has a high incidence of injection site reaction and chills, but low incidence of disease-related side effects like UTI or arthralgia. And there is no immediate onset systemic allergic reaction with degalinrostat, which is the most important side effect of GnRH antagonist. But there is no significant serious side effect with degalinrostat. But most injection site reaction occurred with the first dose and decreased after that. From this study, the dose of degalinrostat is fixed. So the initiation dose is 240 milligram, and the maintenance dose is 80 milligram. And it has thin needle, and there's no need for refrigeration. Next subject is CS42 study, which is open-label, multi-center bridging trial of efficacy and safety of degalinrostat on 1 month dosing in Korean patient with prostate cancer requiring ADT. The primary objective of this study is to establish non-inferiority of degalinrostat in Korean patient versus non-Asian patient with regard to achieving and maintaining the testosterone at the castrated level below 0.5 nanogram per milliliter from day 28 to day 196. Non-inferiority margin limit was 10%. The trial design was the patient received 240 milligram as an initial dose and maintained with 80 milligram monthly basis for 6 months. We enrolled 157 patients, but the 148 patients complete the study. 9 patients discontinued due to adverse event with or patient withdrawal or physician's decision, etc. The prostate cancer Gleason score is much higher in Korean patient compared to the non-Asian patient. Baseline PSA was 19.2. Baseline testosterone level was 4.03. When we look at the result, the cumulative probability of testosterone suppression below 0.5 was 96.7% in our patient. It was 99% in CS21, so it is a little less effective. But the estimated difference in cumulative probability between CS42 and CS21 was minus 2.3. The lower limit of 95% was minus 5.5%. So it is minus 2.3 is above the predefined non-inferiority limit of minus 10%. So we can prove the non-inferiority of Degarex in this trial. The difference of median testosterone suppression over time in CS42 and CS21 was not significant. And the percent change in PSA over time was similar between two studies. But we have also frequent injection site reactions like pain or erythema, but most of them associated with the initial dose decreased with over time. 2 patients died due to disease progression. As a conclusion of CS42, the efficacy and safety of Degarex in Korean patients is similar to that in non-Asian patients. Degarex suppressed the testosterone and PSA rapidly and maintained the suppression. So that result makes the Degarex as an effective first-line androgen deprivation therapy for the advanced prostate cancer. Lastly, I'd like to summarize new data for Degarex from 6 randomized trials. The aim of this meta-analysis is the analysis of Degarex clinical trial database to compare disease control parameters, disease-related side effect between Degarex and LHRH agonist. These are meta-analysis of 6 randomized clinical trials with 2,328 patients. The Degarex arm is 1,491 patients. LHRH agonist arm is 837 patients. So, and their patient characteristics are well balanced. The result is analysis for the disease control over survival and side effects like skeletal, urinary tract, and cardiovascular effect. Degarex showed the sustained testosterone suppression, almost the same as LHRH agonist, but Degarex shows the rapid testosterone suppression compared to leuprolide. Also, the Degarex suppressed the PSA more rapidly, but similar level of that of LHRH agonist. Degarex also reduced PSA more rapidly than LHRH agonist, and the PSA progression is more frequent over time with more advanced disease, and the PSA progression is more frequent with a high PSA level. But Degarex shows the improved PSA progression-free survival with the patient with the PSA level over 50 nanogram per milliliter compared to LHRH agonist. And Degarex shows better control over serum alkaline phosphatase compared to LHRH agonist plus flare protection. This is an important slide. because Degalis shows improved overall survival than LHRH agonist. So, as a summary of efficacy, Degalis, it is associated with improved level of disease control and prolonged time to castrate-resistant disease. It increased PSA progression-free survival in patients with high PSA level, and also increased greatly suppressed serum alkaline phosphatase, and importantly, improved overall survival compared to LHRH agonist. In terms of adverse event, Degalis also has a higher incidence of injection site reaction like a pain, erythema, swelling, nodule, but it shows low incidence of arthralgia, back pain, and UTI compared to LHRH agonist. It shows fewer disease-related skeletal adverse event compared to LHRH agonist, and the joint-related sign and symptom is less frequent with Degalis. And arthralgia also low with Degalis, and the fracture is also low with Degalis. When we look at IPPS, Degalis shows the low symptom index. Also, low incidence of urinary tract event can be observed with Degalis compared to LHRH agonist. This is the study of prostate volume comparing the Degalis and goserelin plus bicalutamide. Degalis decreased the prostate volume for about 42%, but goserelin plus bicalutamide decreased the prostate volume about 25%. So that can cause the lower urinary tract, also the low urinary tract infection rate was less frequent with Degalis. And this is also important side effect. Cardiovascular event is less frequent with Degalis compared to LHRH agonist. The risk of cardiovascular event or death is decreased with Degalis in all patients. But in patients with no baseline cardiovascular disease, the risk of cardiovascular event or death is similar between Degalis and LHRH agonist. But in patients with baseline cardiovascular disease, the risk of cardiovascular event or death is significantly decreased with Degalis compared to LHRH agonist. So I'll conclude my presentation. Degalis is associated with the improved level of disease control and also improved the overall survival, and has a fewer disease-related side effect, significantly decreased the risk of adverse event in skeleton and urinary tract. And in patients with pre-existing cardiovascular disease, it has significantly fewer cardiovascular event, has a relative risk reduction of 50%. From this data, we can confirm the use of Degalis as a first-line medical treatment for patients with prostate cancer in need of ADT. Thank you for your attention.
Thanks, Professor Kim, for your very interesting talk.